Hello, my name is Carisi Polanczyk. It's an honor to be here to talk in this conference with my colleagues Anna and Sheila Martins about the importance of how to use TD-ABC to increase value in healthcare. This is our conference. Next, Anna, please. We do not have any conflict of interest to declare regarding this presentation. And I guess we can start saying that the name of this, go ahead, Anna. The name of this presentation relates to the use of TD-ABC to increase value. I'll introduce myself. I'm professor of medicine at the Federal University of Rio Grande do Sul, here in the south of Brazil. Also chief of cardiology at Hospital Moinhos de Vento, and coordinator of a National Institute for Health Technology Assessment. Anna?
I'm a postdoctoral researcher in epidemiology at the Universidade Federal do Rio Grande do Sul, researcher at the National Institute for Health Technology Assessment, and professor at the engineering school at the Catholic University in the south of Brazil.
Hi, I'm Sheila Martins. I'm professor of medicine at the University Federal of Rio Grande do Sul. I'm head of neurology and neurosurgery in Hospital Moinhos de Vento. I'm president of Brazilian Stroke Network and president-elect of World Stroke Organization.
So this is our agenda for today. We'll be talking a little bit about the health system in general, healthcare, what are the challenges for the next few years, and how VBHC fits in all of this, and the use of TD-ABC in this context. And then I will ask Sheila to share with us the stroke care reality worldwide and here in Brazil, and some work that she's been doing and how it fits with this study that will be presented by Anna, that moving the Brazilian ischemic stroke pathway to value-based healthcare, and share with you some of our experience or beginning of our experience. So just to give an overview, what's our institute or what are we doing? We are a group of scientists, so clinical research, epidemiologists from different fields of medicine. We've been working a lot of different aspects of health technology assessment, clinical studies, and lately, I would say, since 2017, introducing some studies and ideas about value-based healthcare concept. Here are some of the publications. We had the opportunity to use this methodology, time-driven activity-based costing, looking at heart transplant and bone marrow transplant patients, how to apply for telemedicine fields, especially ophthalmologic diagnosis in primary care, prostate cancer, and so on. But we'll go in deep looking at the stroke patients, and we'll see some of the details. So just to put into perspective, we are all aware of the problems that all healthcare systems are facing lately, and this is to talk about prior to the pandemic, so we have something else to add now, the pandemic that is going on, but I'll just keep out of this and looking in a more general perspective what's going on. And if we can share this information that was published last year, it's really interesting that Deloitte put together that it's expected that healthcare spending will increase roughly 5% yearly in the next couple of years. And the global healthcare spending as a share of the GDP for every country is around 10% with some heterogeneity, and probably will stay around 10%. And maybe the most important thing is that this expanding will continue in a heterogeneous or unevenly way. We have values very high, more than 10,000 per capita in the United States, and we have several countries that expense less than $100 per patient or per person. And there are a lot of factors that are being pointed out that why this is happening. We are all aware that population is growing. We have increased economic power. In a way, it's really good, but the population is also expecting us to offer more, and they are waiting to receive more health in return. And there are a lot of movements talking about the expansion of public health care systems worldwide. Next. We know that the cost in healthcare, this is data from 2018, but probably is really updated, that we have a lot of uneven distribution of this cost. Countries, even in the same continent, spending very different values. And we know we here in Brazil, we are in the right side of this graph. We don't have a lot of money. We need to offer a lot of things to our patients, to our population, and it's really a challenge thing. More three aspects that needs to be pointed out, that when we talk about technology and what we would like to implement for our patients, it always came to mind advances, therapeutics in diagnostics, in robotics, and even in new medicines. But we know that this probably will continue and is growing a lot, and it's really good because we'd like to offer this to our patients. But we are also aware that there are other things going on and that will consume a significant amount of money. Go ahead. And if we look at the perspective for the near future, there are a lot of things going on in the digital area. Actually, we are talking about the new future, that we need to put this in the healthcare expenditure, and this will be really great. It could be something, and probably will be something important, great for our patients, but we probably will share the same amount of money that we already have in our healthcare system. So we need to be aware that we need to use all this information, but in a very constructive way. Otherwise, we'll just shift one thing to another. And the other aspect that is really important for the future is the concept that the population is aging. We have more and more elderly patients that are surviving acute disease, and they are luckily with us, but they are piling up, they are adding up a lot of comorbidities. So we have a growing population, older and with more comorbidities, that probably will be spending more and more in the years to come. So this is the future. We know that all healthcare systems, they have problems, and one of the problems also related to waste in the healthcare. This is a study published in JAMA, yes, in the end of 2019, where they try to estimate where most of the money is going on, and they estimate that there are a lot of things, at least in the US system, that kind of leaks the money and related to the failure to deliver healthcare, how the system is not coordinated towards what really matters to patients. And there are a lot of things that could be done to save money in a ways that we deliver something more, and I'll talk to this, more of value to the patients and the society. So this is not something new. It's been in the health system agenda in the last decade or so. The concept that we need to look at our system in a different way. We need really to be more critic in the way how we deliver the system, how we deliver healthcare to our patients, how they perceive this, not in a way only to be cured, but how they feel about this, and if the results that we are achieving really matters to them in a good way. So value in health system, this is a ported concept. It's being the relationship between the outcomes that we can achieve divided by the cost that we deliver these outcomes. And we can increase value basically in three different ways. We increase the outcomes, keeping the cost. We can keep the outcomes, but reduce the cost, or the ideal scenario, we could increase the outcomes and deliver more for our patients and be able to reduce costs. So this is probably the agenda that we will be discussing, how to increase value to our patients using this as a reference for our new design or new way of thinking how to treat our patients in different conditions, in different scenarios. Anna? And going specific in what we are talking about, how to increase value, how really change our design, I will ask Sheila to share with us some ideas and thoughts about the stroke care pathway in Brazil.
Thank you, Carisi. Well, next, Anna, please. Since 1995, we know that acute stroke care changed a lot. And since then, we have to organize to assist as an emergency, emergency in the hospitals. So we have 3 evidence-based interventions, level 1A, that are the organization of stroke units with exclusive beds with a multidisciplinary team to assist acute stroke care. We should implement thrombolysis with TPA for patients up to 4.5 hours of symptoms onset, and you should implement thrombectomy for patients with large vessel occlusion up to 8 hours of symptoms onset, and sometimes with selected patients up to 24 hours of symptoms onset. So next one. We know in individual level that if we implement the stroke unit, you can decrease 14% of the disability of patient. If we implement TPA for acute ischemic stroke, you can decrease in 30% of disability, thrombectomy 50%, but in population level, you can use much more stroke unit where you can put all patients with stroke. TPA will use in 15% of ischemic stroke patients and thrombectomy in 5% of patients. So all of these strategies are important, but you should start organizing stroke units. And how to implement this in a country, a continental country as Brazil, with more than 200 million inhabitants, with a public health system paid by the federal government. Only 20% have additional private healthcare insurance. 80% of patients are assisted in public health care. And a good news is that we have a strong pre-hospital, national free pre-hospital to take this patient and put these patients in the right hospital in acute stroke care. Next, please. We have more than 400,000 strokes per year in the country. Stroke was the leading cause of death in the last 20 years, with more than 100,000 deaths each year. This changed since 2011 because of the organization of acute stroke care, and now stroke is the second cause of death, but we have still more than 100,000 deaths per year. We have several challenges for organized stroke care in Brazil, because the Ministry of Health told us that we have overcrowded emergency rooms, and it's true, mainly in public hospitals. We had lack of intensive care unit beds for safely treat these patients, and we have lack of space to create stroke units in 20 years ago. We have lack of health professionals trained to treat those patients, and because the cost of TPA, that was a concern to the Ministry of Health. Next, please. So how we start? We start evaluating the cost effectiveness of thrombolysis in the stroke in public health system. Next. And we saw that thrombolysis in public health is cost effective and saves money after the second year after the treatment. Next. So since the TPA was approved to be used in 1995, Brazil started the organization for local efforts with TPA paid by the health manager, local health managers, or university hospitals. So in 2008, we had 35 hospitals with acute stroke care developed by local efforts, and 15 were public, paid by local health managers. And you show to the Ministry of Health that was possible to implement acute stroke care in Brazil, including in public hospitals, and that the treatment was cost effective. You show them that time with local registries, we show that we had more than 3,000 patients thrombolized with the same international results. For this, Ministry of Health called us to organize a national project of stroke based on the fast rescue of SAMU. This is the meeting in the Ministry of Health with neurologists together with representatives of the Ministry of Health to create the pilot for the national project of stroke. Next, please. And together with this, we found the Brazilian Stroke Network to work together with the Ministry of Health in this project, in this implementation. With the mission to improve assistance, education, and research and stroke. Next, please. And we start with the creation of a national stroke program, and we start to visit the whole country to evaluate the situation, the local resource, and the personnel available to implement acute stroke care. We visit the hospitals to evaluate the situation, and we create a project tailored to each region of the country. In 1 year, we create 90 stroke units in Brazil with local investments from the health managers. And after this, we implement training and education of population. With the results of the pilot project, we saw that it was possible to implement stroke centers in Brazil with local investments. And we have very good results in the pilot project with a network organized with 3 hospitals in south of Brazil, including telemedicine for the stroke. Next. So in 2012 was published the National Policy for the Stroke with approval of TPA in public hospitals for thrombolysis, and with the creation of stroke centers in Brazil in 3 different levels, including the better budget with patients assisted in stroke units. Next, please. And organization of line of care, the whole stroke care since the emergency room until the rehabilitation and secondary prevention. We start that time organizing the acute stroke care in the implementation of stroke units. And this was in 2013 with acute stroke unit, rehabilitation stroke unit, and the most important, the multidisciplinary team organizing to assist those patients and to improve the outcomes. Next, please. Very important was to monitor this data. So you can see here the quality indicators. Before the organization of acute stroke care, we had in ischemic stroke 12% of mortality. With the national policy, with the acute stroke care, we decreased the mortality for 9%, and after the national policy, we decreased the mortality for acute ischemic stroke in 5%. Next, and you saw we decreased the length of hospital stay from 22 days before the organization of acute stroke care to 12 days with acute stroke care, and to 7-8 days after the organization of the whole stroke care inside the hospital. Next. With this, the mortality in the whole country has been decreased in Brazil, and since 2011, stroke is the second cause of death. Next, please. In December 2019 was launched a full line of care led by Carisi. The first line of care was stroke in a platform to be feasible to access by health professionals in any time, in any point of stroke care, to see the protocols and to treat these patients. Next. And it's very important, the implementation of acute stroke care. You can see here the difference. Joinville was our first stroke unit in Brazil, and you can see the first and second bars, the good outcomes in Joinville. You can see Canoas, the last here, that is a stroke unit to the city. This was a city-based level research where we evaluate all strokes during 1 year in each of these cities. So Joinville, the outcomes in 3 months disability was much better. Canoas, that is a city with stroke units, was good too. And Sertãozinho with Sobral, with any organization of stroke care, you can see the disability was too high in those patients. Only 20% of patients with good outcomes with no disability. And mortality, click one, Anna, please. You can see the mortality that is unbelievable. You can see Joinville, 19% mortality in all strokes. Canoas, it's bad, but they have more severe patients, is 31% of mortality. In areas without acute stroke care organization, 44% of mortality. That is not possible. So for this, we should implement more, and you should monitor the data to show these results. Here is the difference. In 2008, the Organization of Stroke Care, 35 stroke centers. Now we have more than 200 stroke centers in Brazil. Next. And we start to think how to monitor this data, and it's important to implement patient-reported outcomes with the outcomes that matters to the patients. So we start the International Consortium for Health Outcomes in 2015, together with the publication. I participate in international group that create this standard set. Here is the publication. Next, please. And we start the implementation in Hospital Moinhos de Vento and Hospital de Clínicas de Porto Alegre and telemedicine hospitals in that time, 2015, to monitor those patients. Here is just an example. Next, please, showing the difference between private and public hospitals with the same protocols, but you can see that in public hospitals, the patients were younger, they were more severe, and much more risk factors. You can see in the right column. Next, please. And you can see here in the outcomes, functional independence, 51% in patients in the private hospitals and 39% in the public one. Next, please. And you can see here the patient-reported outcomes, only a few examples. 30% that need help to dress or undress, and 60% in public. So in public hospital, you have much more disability than in private ones, because they were more severe and more comorbidities. Next, please. So this is very important to monitor in the whole country. We also validate the thrombectomy in public hospitals in Brazil. This is a New England publication last year, a study from the Ministry of Health of Brazil. Next, please, that showed that the treatment, comprehensive treatment, is feasible in public health system in Brazil, is effective and cost effective. Next, please. And for this, the treatment now is approved to be used in public hospitals in Brazil since 1 month ago. Next, please. So we're starting now the certification of stroke centers to ensure that all evidence-based level 1 evidence-based strategies are implemented, and we need a national register to monitor these patients and to see the value of these treatments. So for this, Anna will talk a little bit more what we are doing. Thank you.
Thank you. Thank you, Sheila and Carisi. Now with this context, we started this project that has the objective to introduce a value-based healthcare program for the ischemic stroke care pathway in Brazil, and to contribute to redesign a national reimbursement strategy. At this time, we are sharing the results from the first center, that is Hospital Moinhos de Vento, which is a private hospital, but we continue this research, collecting and analyzing the data from other 2 public hospitals. And the idea is to continue this evaluation that Sheila was sharing about the differences and understand how to make better the delivery of care in both systems, public and private. Well, for you design that research, we followed the value agenda, and we divided the measures that we started to collect the data in outcomes and costs. For the outcomes, we considered the ranking and mortality as the main functional measures to be evaluated. And for the process of recovery, we considered the ISHOM standard set. And in addition, we used a few measures that are representing the hospital process of care, As an example, we are evaluating the time between patient arrival and be submitted to the tomography, and the time between patient arrival and be submitted to the hyperfusion therapy for the patients that were treated with the hyperfusion therapy. And also length of stay and infections, risk events that sometimes patients were submitted to. But we understand that maybe for the cost side of this study, we advanced because we applied the TDABC, the time-driven activity-based costing, to evaluate the cost in a patient level for the stroke care pathway. And nowadays in the literature, we don't have a study that applied this method to evaluate costs in that level. And we used the power of the method here to introduce a model, an equation to start to estimate the cost per patient for considering the therapy that is being used to treat the patient and the risk level that the patient arrive at the hospital. We are evaluating our data using these groups, and these groups are considering the technology or the therapy that is being used, hyperfusion or antithrombotic therapy, and the risk level. And for the risk level, we are using these two variables, the patient age and the NIH. And all the analyses here are considering the risk level and the therapy. And we are working with more data now to turn better this model. And you understand that for you achieve our big goal to introduce and discuss reimbursement, we need to include that level of sample stratification to really suggest a reimbursement strategy that can value the quality of care, the technology, and the comorbidities that the patients presents when arrive at the hospital. Here we have our sample description, and at this hospital we collected data from 274 patients. We can see that hypertension was the main comorbidity between the patients of our sample, and considering the therapies, what we expected is shown here, that yes, the patients treated with hyperfusion therapy presented a higher cost, and patients treated with antithrombotic therapy a lower cost. And regarding the clinical condition, the patients treated with antithrombotic therapy arrived at the hospital in a better condition than the other patients, and especially when we see the thrombectomy, we can see that patients that were treated with that technology arrived at the hospital in a more severe clinical condition. And also it's important to highlight here that this hospital is a reference center, a private reference center to treat stroke patients. And this data here at these hospitals, we have the protocols to use that technologies, what is not real in all the country, as was being explained by Sheila in the previous presentation. Well, about the cost, here at these charts, we can see that the incremental cost associated to the use of hyperfusion therapy is not only associated to material and medications, but yes, we have an important incremental cost associated to ICU. And this, for we discuss the reimbursement strategy, is super important, that we need to understand that incremental cost of the technologies is not only materials and medications. We need to value and understand that patients that are being submitted to that technologies are consuming much more healthcare service and hospital structures. And this may be considered at the time to define a reimbursement strategy. Okay, but how the risk levels help to evaluate the technology value added? I guess that here we have a point that we are trying to explore a lot in our analysis. And here we can see that in all the risk levels, the hyperfusion therapy represented a better favorable outcome. Considering a favorable outcome, the modified ranking score between 0 to 2. and unfavorable outcome, you are using 5 and 6. But the main point here is that the difference in the ranking score was more expressive for the high-risk patients. And here we are using this measure that is the ranking and the mortality. But since the beginning of the study, our idea was to advance to evaluate the impact on the measures that matter to patients. And is why we started to understand, okay, but how about the ISPOR measures, what is happening with patients that were treated with antithrombotic therapy and reperfusion therapy in these 3 risk levels. And at this chart here is illustrative how you can see that for high risk patients, the reperfusion therapy demonstrated a higher performance for all the ISPOR indicators. And when we see the cost that is at this level of the chart here, the difference in cost between the 2 groups of therapies is smaller than when we compare patients that were classified with low risk or medium risk. These charts are in a descriptive way, suggesting that for high-risk patients, we have an important incremental result in outcomes, and the differences in cost is smaller than when we use the technology for low or medium risk patients. And this is what we started to explore a little more by introducing this model here. This is one of the objectives of the study, and we treated this data in a sequence of regression analysis here to achieve that equation. And by this model, you can estimate the cost per risk level and considering the therapy. For example, if the patient was treated with antithrombotic therapy and is low risk, we have an estimated cost of 2,687. And this cost is incremented in each risk level, and also when we change the therapy used. And by applying the model, we certainly showed that the feeling that we could see at the charts that we saw before, that the incremental cost associated with reperfusion therapy was proportionally lower for high-risk patients, and the incremental cost between the risk levels was proportionally higher in antithrombotic therapy. We're continually working on more data to answer how much is it the incremental cost to increase one level in each ranking scale, and how the reimbursement strategy can contribute to guide the effective use of the technology in the stroke care pathway in Brazil. I guess that our expectative is to explore and evaluate a large number of data. Now we are working with data from 800 patients from the other hospitals, and we are exploring a lot the TDABC granularity of cost information to show how we can use better the technology and increase value for patients in the stroke care pathway. We understand that by introducing this value program for the stroke care pathway, this study innovates and starts to demonstrate that measure costs and measure outcomes that matters to patients contributes to increase the management capability for the care pathway. And all these results will be very important for we start to discuss a reimbursement strategy that can match better the real costs that we have nowadays at the hospital level in our country. And answering the main question of this session, why measure cost is essential to increase value. We understand that, yes, to understand better and accurate cost information is essential for introducing reimbursement strategies sustained on value, identifying waste reduction opportunities in healthcare, especially when we start to run these studies in several centers. We can see the differences in process of care and how you can use better the technology and the service. And we are trying to explore that in our analysis. And considering the equation, we are dividing outcomes per cost is not possible. We integrally implement value-based healthcare if you don't have one variable that is cost. And for you do that, we believe that yes, that TDBC is helping us to do it. We thank you very much for your attention today.